hormonal regulation, hypothalamus pituitary axis, with 4 answer choices and detailed explanations. Endocrinology, clinical vignettes, hypothalamus pituitary axis, 1. Hypothalamic regulation of prolactin. A 35-year-old woman presents with amenorrhea and galactorrhea for the past 3 months. She denies pregnancy. MRI reveals a pituitary microadenoma. Which hypothalamic factor is responsible for regulating prolactin secretion? A. Growth hormone-releasing hormone, GHRH. Corticotropin-releasing hormone, CRH. C. Dopamine. D. Thyrotropin-releasing hormone, TRH. Answer C. Dopamine. Explanation. Dopamine inhibits prolactin secretion from the anterior pituitary. A prolactinoma causes increased prolactin, suppression of GnRH, amenorrhea, galactorrhea, and infertility. Pituitary adenoma, mass effect. A 55-year-old man presents with bitemporal hemianopsia, headaches, and fatigue. MRI shows a 3 cm pituitary adenoma. What structure is most likely compressed? A. Internal carotid artery. B. Optic chiasm. C. Hypothalamus. D. Cavernous sinus. Answer. Explanation. Large pituitary tumors compress the optic chiasm, causing bitemporal hemianopsia, loss of peripheral vision. Other mass effects include headaches and hypopituitarism. 3. ACTH-dependent Cushing syndrome. A 42-year-old woman presents with central obesity, moon facies, hypertension, and muscle weakness. Lab results show elevated cortisol and ACTH. Dexamethasone suppression test fails to suppress cortisol. What is the most likely diagnosis? A. Adrenal adenoma. B. Pituitary adenoma, Cushing's disease. C. Ectopic ACTH production, small cell lung cancer. D. Addison's disease. Answer B. Pituitary adenoma, Cushing's disease. Explanation. Cushing's disease, pituitary ACTH overproduction, presents with elevated ACTH and cortisol. Ectopic ACTH, e.g. small cell lung cancer, causes more severe hypercortisolism and fails to suppress at high-dose dexamethasone. Diabetes insipidus, ADH deficiency. A 27-year-old man presents with polyuria, polydipsia, and nocturia. Serum sodium is 148 millicurie and urine osmolality is low. After administration of desmopressin, ADH analog, urine osmolality increases significantly. What is the most likely diagnosis? A. Nephrogenic diabetes insipidus. B. Central diabetes insipidus. C. Primary polydipsia. D. SIADH. Answer B. Central diabetes insipidus. Explanation. Central di is due to ADH deficiency, e.g. from hypothalamic or pituitary damage. Urine osmolality increases with desmopressin. Nephrogenic di shows no response to desmopressin. HANA 5. Syndrome of inappropriate ADH, SIADH. A 65-year-old man with a history of small cell lung cancer presents with confusion, seizures, and nausea. Lab tests reveal hyponatremia, low serum osmolality, and high urine osmolality. What is the most likely cause? A. Hyperaldosteronism. B. Central diabetes insipidus. C. ADH. D. Addison's disease. Explanation. SIADH leads to hyponatremia and concentrated urine due to excess ADH release, often from small cell lung cancer. Treatment includes fluid restriction and hypertonic saline in severe cases. 6. Growth hormone excess acromegaly. A 50-year-old man complains of increasing shoe size, jaw enlargement, and excessive sweating. Lab tests show elevated IGF-1 and failure to suppress GH with oral glucose. What is the best next step? A. Measure TSH and free T4. B. MRI of the pituitary. C. Dexamethasone suppression test. D. Genetic testing for MEN1. Answer B. MRI of the pituitary. Acromegaly is caused by a GH-secreting pituitary adenoma. GH levels do not suppress with glucose, and IGF-1 is persistently elevated. MRI confirms diagnosis. 7. Hyperprolactinemia and hypogonadism. A 29-year-old woman presents with irregular periods, infertility, and galactorrhea. Serum prolactin is elevated, and MRI shows a 2 cm pituitary mass. What additional lab finding is expected? A. Low LH and FSH. B. High estrogen. C. High testosterone. D. Low cortisol. Answer. A. Low LH and FSH. Explanation. Prolactinomas cause suppression of GnRH, leading to low LH and FSH, resulting in amenorrhea and infertility. 8. Hypopituitarism. Sheehan syndrome. A 32-year-old woman presents with failure to lactate, fatigue, and weight loss 3 months after postpartum hemorrhage. What is the most likely cause? A. Pituitary infarction. B. Prolactinoma. C. Hypothyroidism. D. Addison's disease. Answer A. Pituitary infarction. Explanation: Sheehan syndrome is ischemic necrosis of the pituitary due to severe postpartum hemorrhage, leading to panhypopituitarism. 9. Hypothyroidism and TRH stimulation. A 49-year-old woman presents with fatigue, weight gain, and cold intolerance. TSH is high and free T4 is low. What is the most likely response to TRH stimulation? A. Decreased TSH release. B. Increased TSH release. C. No change in TSH. D. Increased cortisol. B. Increased TSH release. Explanation: Primary hypothyroidism, e.g. Hashimoto's, leads to increased TSH in response to TRH stimulation due to lack of negative feedback from T4. 10. Pituitary apoplexy, acute presentation. A 60-year-old man with a known pituitary adenoma presents with sudden headache, vision loss, and hypotension. What is the best initial management? A. Transphenodal surgery. B. High-dose corticosteroids. C. Dopamine agonists. D. Radiation therapy. B. High-dose corticosteroids. Explanation: Pituitary apoplexy is caused by hemorrhage into a pituitary tumor, leading to acute adrenal insufficiency, low ACTH cortisol. Immediate corticosteroid therapy is life-saving. Key takeaways for the hypothalamus pituitary axis. Dopamine inhibits prolactin. Prolactinomas cause amenorrhea and galactorrhea. Pituitary tumors compress the optic chiasm. Bitemporal hemianopsia. Cushing's disease. ACTH-secreting pituitary adenoma. Central diabetes insipidus responds to desmopressin. SIADH Hyponatremia with concentrated urine, often from lung cancer. Acromegaly IGF-1 elevation and GH does not suppress with glucose. Sheehan syndrome. Postpartum pituitary infarction. Pituitary apoplexy, sudden vision loss, and adrenal insufficiency. Would you like vignettes on adrenal disorders, Cushing's, Addison's,